So just a brief caveat. I just want to emphasize at the outset that the standard of care for locally advanced rectal cancer is and remains chemoradiation. No question about it. Neoadjuvant chemotherapy, which I'm going to talk about, is an investigational strategy, but this is a postprandial debate, and I need to keep you awake, so I'm going to take an unconventional approach. Just to be clear, the efficacy of neoadjuvant chemotherapy without radiation has not yet been established in the context of well-controlled prospective clinical trials. So what I want to try to do today is persuade you that a trial to compare neoadjuvant chemoradiation to neoadjuvant chemo with selective radiation is a priority question in contemporary management of rectal cancer. I want to describe the rationale for neoadjuvant chemotherapy, and a lot of it just comes from logical principles of oncology, and then to describe trials that have evaluated this question, both in the pilot phase and phase 2 experience, as well as some phase 3 trials that are in progress. So this is the, oops, I'm not sure why that's cut off, if you guys can fix the top, but this is the current rectal cancer treatment paradigm, mostly in the United States, which consists of long-course chemoradiation with about 5.5 weeks of combined modality therapy with radiation and sensitizing 5-FU, followed by a variable recovery period, and then surgical resection with a TME rectal operation, again, a recovery period, and adjuvant systemic chemotherapy. What this ultimately means is that systemic chemotherapy, particularly for patients who are at high risk, node positive, for example, is delayed at least 3 to often 4, even going up into 5 months from the initial presentation. So how did we get here? How did that become the standard? Well, everyone knows that really the standard for giving radiation in rectal cancer dates back to 1990, but it was really solidified in 2001 with the publication of the so-called Dutch TME trial. And this trial compared high-quality TME resection to high-quality TME resection with the addition of preoperative radiation therapy. This was a large trial published in the New England Journal of Medicine, and the upshot of the trial is that radiation added to the TME alone. So patients who had both TME and radiation had lower rates of local recurrence at 4 years. You can see in the slide, 6% better than 11%. Now, it's important to note that these rates of local recurrence in the so-called TME era are a lot better than the 50% rates that were experienced back in the 1980s and 90s, but still radiation had a clear and compelling benefit that was absolutely statistically significant. However, overall, in the long term, this did not impact overall mortality rates. The follow-up of this study, long-term follow-up, was published in Lancet Oncology in 2011, and with lots of long-term follow-up, there was ultimately no difference in survival. So given that we know that radiation provides a benefit, the next question on the docket, which we were not able to answer in the United States, was when's the best time to give chemoradiation? Before surgery or after surgery? And that study was elegantly conducted and addressed in the German trial, a randomized trial of about 800 patients comparing pre- and post-operative chemoradiation. The winner was pre-operative radiation. Local recurrence rates were lower when radiation was given preoperatively, and grade 3 to 4 toxicity was also superior. However, again, overall survival rates and distant recurrence did not differ. But the way this trial has been interpreted, and the clear conclusion, is that preoperative chemoradiation is preferable to postoperative chemoradiation. So why should we question the use of neoadjuvant radiation? Well, I think we all know, because we've encountered patients who experience both the short-term and long-term morbidities associated with radiation, and multiple meta-analyses have demonstrated this. I think the other reason has to do with the fact that progress has been made on many fronts since this care standard was established. In the meantime, we've had significant advances in imaging. We now have widespread availability of pretty high-quality MRIs that enable us to characterize T-stage quite reliably, as well as to assess the potential for obtaining a clear circumferential radial margin. We've also had better surgery as knowledge in the surgical community and expertise and training in terms of dissemination of modern TME techniques has advanced. We also obviously have had better systemic chemotherapy with adjuvant FOLFOX coming on the scene for colon cancer starting in 2004. And the other thing we have is we have more screen-detected rectal cancers as colonoscopy screening rates have increased in the population, so that there's a within-stage migration so that your typical rectal cancer, even a T3, they're smaller than they were a decade or two ago. Oncologists also have practical experience using neoadjuvant chemotherapy in a couple of pretty common clinical situations. The first is among patients with stage 4 rectal cancer. When those patients present, sometimes with a small liver met or someone who you think you may be able to convert to standard treatment plus a metastatectomy, people will often start with systemic chemotherapy and note that there's a very high response rate to so-called induction FOLFOX. People also have clinical experience treating rectal cancer without radiation in a set of so-called special cases. We, these days, have lots of men in the population who've been treated for prostate cancer and have a history of brachytherapy or pelvic radiation for that malignancy. We also have women who've had pelvic radiation for GYN cancers, and therefore they can't get radiation for their rectal cancers. Of course, we have a small group of young women who are seeking fertility or childbearing preservation, and we have a small group of people who are extremely concerned about preserving sexual function. So many oncologists occasionally encounter these patients in practice, and there's a large number of case reports in the literature describing high response rates to induction chemotherapy in this context. So some challenges that arise from the neoadjuvant paradigm. Distant disease remains the primary site of recurrence and the cause of death in rectal cancer. And we face a paradox. There's an undertreatment risk. Node-positive patients, we know, often don't make it all the way through their post-op systemic chemotherapy. The converse is we also face an overtreatment risk. Node-negative patients may get unnecessary treatment that they don't really need. We also know that patients experience significant myelosuppression from pelvic radiation, which can impair their chemotherapy tolerance downstream. We also know that metastatic rectal cancer patients in trials of advanced disease typically receive less chemotherapy and ultimately have inferior survival compared to metastatic colon cancer patients, and many have questioned whether the radiation explains that to some extent. So one of the first studies that provided some compelling data for use of neoadjuvant systemic chemotherapy was a UK phase 2 study where patients got some induction K-pox, an MRI, and then standard chemoradiation and another MRI, and the investigators looked at the clinical response rates as assessed by the MRIs. And what you can see is that in this slide is that partial response rates were exceptionally high when patients were restaged after several cycles of induction K-pox, again suggesting that intact rectal tumors they're just very sensitive to FOLFOX. So these experiences led us a number of years ago, a number of the investigators are in the room, to launch a small single-center pilot study at Memorial Sloan Kettering, where we gave 6 cycles of FOLFOX and Bev to patients with early-stage, favorable risk, highly selected, good risk group of rectal cancer patients who were all candidates for low anterior resection at presentation. And the idea was to administer radiation therapy if there was no response to the induction FOLFOX or any positive margin. Of 32 participants, none required preoperative therapy, and with more than 4 years of median follow-up, there have been no local recurrences, and a number of patients have developed lung metastases and 1 acute post-op death. This pilot study, very small, single center, highly selected, was published about a year ago in the JCO. I've put up here The 4 studies to date, these are all pilot studies that look at neoadjuvant chemotherapy without the routine use of systemic chemotherapy. The first one listed here is from Japan and used induction IFL. The second one from Spain, and you can see all these studies have just around 30 patients. Again, very favorable R0 resection rates and reasonable pathologic CR rates. So to really try to move this forward and address this question, we capitalized on this or built on this to design a multi-center phase 2, hopefully into phase 3 clinical trial, which is called Prospect. And the purpose of this study is to see whether not a no radiation strategy, but a selective radiation strategy is a safe alternative to routine use of neoadjuvant radiation in all our rectal cancer patients, which has been the prevailing paradigm since the German study published in 2004. So it's a phase 2 to 3 cooperative group study. The phase 2 part will accrue 366 patients, and we're at 310. And the idea is that there's a stopping rule, safety stopping rule built in if there's an unacceptably high number of failures to complete an R0 resections. This is what the study looks like. The standard arm is just standard therapy, 5FU combined modality therapy, followed by a TME resection. And the intervention arm is 6 cycles of FOLFOX, restaging, and if patients respond, they go straight to TME. If they don't, they have the opportunity to get combined modality therapy, and that's why this is not a non-radiation trial, it's a selective use of radiation trial. Postoperative therapy is at the discretion of the primary physician. So the primary outcomes of the randomized phase 2 portion are the R0 resection rate, time to local recurrence, and should it proceed to phase 3, which of course we don't know yet, will balance time to local recurrence and disease-free survival, given the importance of these outcomes in rectal cancer. So I'm going to skip through the inclusion criteria, other than to say patients who are eligible are not high risk, not bulky N2 patients. The eligible patients have to be candidates for a curative intent, curative intent low anterior resection. So just, we often get asked about criteria for use of radiation in the intervention arm, that is patients who are assigned to only get chemotherapy. We recommend giving combined modality radiation if patients progress at any point during FOLFOX, if restaging shows that they really are not responding, the tumors aren't shrinking based on the MRI, or if patients are unable to tolerate FOLFOX, or if they withdraw consent. There's also an opportunity to give the chemoradiation postoperatively if adverse pathologic features are identified. This is a practical trial. It's a real-world trial. There are no novel drugs or techniques here. These are all techniques that everyone knows. There's also a lot of flexibility built in. IMRT is allowed. Short-course radiotherapy is not allowed. Surgeons submit pictures of the TME for QA, and individuals can choose between capecitabine or 5FU. So I just want to briefly mention 2 other trials. One in the UK is addressing this issue. They're looking at poor prognosis individuals and comparing FOLFOX-Bev to FOLFOXIRI-Bev for 6 cycles, and they're going to assess response in R0 resection rates based on PET-CT. There's a Chinese randomized trial that's looking essentially at a very similar question: chemoradiation, FOLFOX followed by chemoradiation, or FOLFOX alone, and their primary outcome is disease-free survival at 3 years. This is also a phase 2 into phase 3, and we're told that there may be some data at ASCO this year, which we're very eager to see. So conclusions. Neoadjuvant chemotherapy strategies are an investigational approach for patients with resectable rectal cancer amenable to sphincter-sparing TME. Patients with threatened margins are inappropriate candidates for this strategy. I think induction FOLFOX merits serious consideration for patients who can't have radiation due to prior therapy, with stage 4 disease, with suspected metastatic disease, and please consider enrolling them in the Prospect clinical trial to help address this great debate. Thank you.